So, dear colleagues, it's a pleasure to give you a short update on this year's World Conference on Lung Cancer that was held in Singapore. I have to admit that I did not travel to Singapore, but I had a look into the most important presentations and abstracts that have been discussed, and I would like to give you a glimpse into 2 or 3 of the abstracts I think are interesting for all of us. I would like to start with FLAURA2. FLAURA2 is a randomized phase 3 study for patients with EGFR mutation positive non-small cell lung cancer. It's a first-line study, so for patients with newly diagnosed metastatic EGFR mutation positive non-small cell lung cancer. We all know that treatment with third generation tyrosine kinase inhibitor, usually osimertinib, is standard of care. And in this FLAURA2 trial, the investigators now assessed if the addition of chemotherapy, platinum-based chemotherapy, to the EGFR tyrosine kinase inhibitor might improve prognosis. So it was a randomized phase 3 study comparing osimertinib, current standard of care, to osimertinib in combination with platinum, cisplatin, and pemetrexed. More than 500 patients were randomized, 1-to-1 randomized, to OSI or OSI plus chemotherapy. Patients with brain metastasis were allowed to be included in the trial, and this was now the first analysis of the study showing a significant benefit in median progression-free survival with a hazard ratio of 0.62. The overall survival data are not yet mature, so it's definitively too early to draw any definitive conclusions, but with the statistical significant benefit in progression-free survival, this is certainly an important finding, and we have to have a closer look at the further results of the study. Interestingly, also patients with brain mets, as mentioned at the beginning, patients with brain mets were included, and more than 40% of patients included in this trial had brain metastasis, and also patients with brain metastasis had a significant benefit in progression-free survival. Second trial I would like to discuss is for patients with KRAS mutation positive disease. So we all know that KRAS G12C inhibitors are now standard of care. So Sotorasib is approved in the second-line setting. We have different other KRAS G12C inhibitors that are currently investigated, and we have seen the update of Crystal-1. The Crystal-1 trial is the trial with adagrasib, the KRAS G12C inhibitor adagrasib, and the 1-year follow-up that has now been presented at the World Lung Cancer Conference confirmed activity of adagrasib in previously treated patients with a KRAS G12C mutation with an overall response rate of 43%, disease control rate of 90%, and the duration of response of more than 1 year. So certainly intriguing findings for this KRAS G12C inhibitor that is currently investigated in a randomized phase 3 study in Crystal-12. In the second line setting, adagrasib is so far not approved in our country, but this is certainly another important option for patients with a KRAS G12C mutation. There have been several trials presented at the World Lung Cancer Conference investigating antibody-drug conjugates in different settings in non-small cell lung cancer, and I would like to mention some of the trials. For example, there was the presentation of Hertina Lung 01. That's a trial with patritumab deruxtecan, an ADC targeting HER3. We all know that HER3 is an important factor, mainly in patients developing resistance to EGFR tyrosine kinase inhibitors and EGFR mutation positive setting, and results from Hertina-3 have confirmed activity of this patritumab deruxtecan. We have also seen trials, ADC trials with sacituzumab govitecan and with the TROPION-Lung04 trial has been presented with the bottom-up, the TROP2 ADC. So I will not go into all the details of these trials, but it is important because it's the beginning of a new path, I would say, in non-small cell lung cancer, that we will have more data for antibody-drug conjugates targeting different antigens in patients with non-small cell lung cancer. I would like to end up with a trial in mesothelioma, malignant pleural mesothelioma, that is certainly important. It's somewhat provocative, the findings of this trial. That was the MARS-2 trial, a trial asking the question if we should do a resection in patients with malignant pleural mesothelioma. Patients were randomized to extrapleural pneumonectomy after induction chemotherapy or chemotherapy alone without surgery. And the important finding of this trial was that surgery did not improve the prognosis of patients. It was, for the first 4 years of follow-up, the risk of dying was even higher in patients undergoing resection, mainly due to surgical complications after this huge surgery, extrapleural pneumonectomy, with an increased risk of 28% of deaths in the first 4 years. It is important to realize that the adverse event rate was much higher. The risk of having a grade 3-4 adverse event was increased more than 3.5 times in patients undergoing surgery. Quality of life was much poorer in patients undergoing surgery. So this really raises the question of the role of surgery in malignant pleural mesothelioma. It is important to mention that in this trial, all patients underwent extrapleural pneumonectomy. We know that there are different other surgical procedures, pleurectomy decortication, that is now in a standard of care in many centers. This was not evaluated in this trial. So therefore, it's definitively not a trial telling us that we should not evaluate patients for surgery with malignant pleural mesothelioma, but it is a warning. It is important that we discuss all these cases in a multidisciplinary tumor board, that we involve thoracic surgeons at the very beginning, really discuss if the individual patient is a good candidate for surgery after we have seen these data from MARS-2. With that, I would like to end up. I'd like to thank you for your interest, and I'm looking forward to discuss some more data with you at the different other possibilities. Thanks a lot.